Unlike a CT or an MRI, which map static physical anatomy, nuclear medicine maps physiological function. As this glowing radiotracer branches through the vascular network, we are looking at living biological processes in real time. But translating that injected radiotracer into a precise, pixelated image requires the signal to survive a chaotic journey. At almost every stage, it is susceptible to physical and computational corruption. Because we are imaging physiological function, these corruptions don't look like technical glitches. They present as anatomical hotspots or dead zones that easily mimic true pathology. Identifying them requires systematic deduction, not rote memorization. We can categorize these syllabus-level artifacts by tracking them along a physical sequence we'll call the signal pipeline. This schematic maps the 4 distinct nodes where the signal goes wrong. Node 1 represents the physical introduction of the tracer and its normal biological distribution throughout the body. Node 2 covers attenuation, the physical interference that gamma photons experience as they attempt to leave the patient's tissue. Node 3 focuses on the detector level, where mechanical and hardware failures corrupt the incoming signal. Finally, Node 4 accounts for the computational mismatches that occur when we merge functional data with structural data. Using this pipeline allows for the systematic separation of expected physical phenomena from the underlying biological signals we actually want to measure. The signal begins the moment the radiotracer enters the patient, typically via venous injection. A heavy concentration of radiotracer will pool at the exact site of the needle puncture. This creates an intense localized spike in activity that can easily mask adjacent anatomical structures. Look at this anatomical map. If tracer leaks outside the vein, we get extravasation. The leaked fluid is absorbed by the lymphatic system and transported upward. The tracer pools in the axilla, presenting as false positive lymph node activity mimicking metastatic spread. Once the tracer successfully enters general circulation, it naturally settles into predictable physiological sinks across the body. In the head and neck, glucose-avid tracers heavily populate the brain cortex, the salivary glands, Waldeyer's ring in the pharynx, and the extraocular muscles of the eye. Even standard behavior alters the map. A patient who talks excessively prior to the scan will show an anomalous, intense activity spike directly in the larynx. Muscles are heavily active sinks. Hyperventilation forces tracer into the diaphragm, while stress-induced tension highlights the trapezius and paraspinal muscles. Insulin administration before the scan stimulates glucose uptake across the body, diverting the radiotracer from the blood pool into global skeletal muscle. Specific organs also act as natural reservoirs. The cecum and right colon are inherently highly active, while the renal collecting system, ureters, and bladder will pull tracers simply through normal urinary excretion. We also see transient biological states: uterine uptake during menstruation, accumulation in lactating breasts, physiological thymic activity in children, and the activation of brown fat when a patient is exposed to cold temperatures. By systematically stripping away these localized injection errors and natural physiological sinks, we clear the first hurdle in isolating true pathological signals. After the tracer distributes, it decays and emits gamma photons that must travel from deep inside the internal tissue outward to the camera. This diagram illustrates attenuation. When an emitted photon strikes a dense external object worn by the patient, like a metal belt buckle, its trajectory is blocked. The software records a void, casting a distinct false negative cold spot directly onto the detector plane. External metal isn't the only barrier. Dense soft tissue acts as a strong attenuator. Breast tissue, and particularly breast prostheses, frequently cast shadows that mask underlying thoracic structures. Below the thorax, diaphragmatic attenuation is a primary cause of apparent functional defects in the inferior walls of the heart. This severe attenuation at the diaphragm correlates heavily with obese patients, patients with ascites, and those actively on dialysis, where excess tissue or fluid scatters the signal. If the patient moves during the acquisition phase, the physical source of the photons shifts relative to the camera, misaligning the trajectories over the duration of the scan. Before a single piece of hardware registers a hit, tissue attenuation and patient motion can blur the structure and create false negative absences of signal. We now move to the third node, the moment the surviving photons finally reach the detection hardware. This schematic of a gamma camera utilizes a delicate scintillation crystal, a flat, translucent plane backed by a honeycomb array of PMTs. If a single PMT fails, the system stops registering counts there. The result is a perfectly circular dark spot on the final matrix. The scintillation crystal itself is highly sensitive. Thermal or mechanical shock can cause it to fracture, which projects as a stark, linear cold streak across the image. Even if the physical hardware is intact, failures in the camera's underlying software correction matrix will warp the overall quantitative data across the entire field. And subtle, uncalibrated differences in individual detector sensitivity will introduce a mottled, uneven background noise to the scan. Unlike the organic shapes produced by biological sinks, hardware anomalies reveal themselves through strict, unnatural geometries, giving us perfect circles and hard, linear breaks. Modern clinical practice rarely relies on isolated functional scans. We fuse functional SPECT or PET data with high-resolution structural CT data. Look at this 3D wireframe camera representing a SPECT acquisition sweeping around a patient. If the software's presumed central axis of rotation fails to match the actual physical axis, we get a center of rotation error. The back projection algorithms push data to the wrong spatial coordinates, smearing point sources into blurry, ring-like distortions. Moving between modalities introduces further risks. If a patient changes position between the radionuclide scan and the CT scan, the images misregister, misaligning the anatomy. But the most significant hybrid trap occurs when the spatial limits of the two cameras fail to match. This diagram illustrates truncation. The large dashed circle is the SPECT field of view. The smaller solid circle is the CT field of view. Any patient tissue in that outer crescent-shaped gap completely lacks structural data from the CT. Without that CT data, the software cannot perform accurate attenuation correction for the functional scan. Missing this critical mouth results in severe artificial edge artifacts appearing directly at the boundary line of the CT field. Integrating high-resolution structural CT data is meant to clarify the image, but if the physical geometries are not perfectly synchronized, the structural data will paradoxically corrupt the functional map. Anomalous signals, geometrical distortions, and noise are guaranteed features of nuclear medicine. They are physical realities of the imaging process. We solve them by moving systematically through the signal pipeline. False positives emerge from the first node, driven by localized injection issues and systemic physiological sinks. False negatives and sharp geometric errors stem from nodes 2 and 3, created by photon attenuation in tissue and mechanical limits in the PMT hardware. And artificial edge borders and spatial distortion originate in the final node, a result of field of view limits and computational mismatch. Mastering this sequence of physical events allows a radiologist to cleanly identify and strip away the noise. Only then can you evaluate the true pathological signal left underneath.